So my name is Helen Morton. I'm a urology registrar from the UK and I have no disclosures. The penile cuff test was developed in Newcastle upon Tyne following on from basic principles of penile compression and release manoeuvres developed by Gleason and McRae and Sullivan and Yalla. It's an automated inflatable cuff which starts inflating once flow has commenced. It inflates at a linear rate of 10 centimetres of water a second until flow is interrupted. At that point, it holds for 2 seconds before it's releasing, allowing the patient to continue to void, and the cycle continues again. The pressure that it generates, and the reading we get, is the cuff pressure at interruption, which is known as P cuff int, and this is an estimation of isovolumetric bladder pressure, which is an established way of investigating bladder contractility. Non-invasive urodynamics has huge potential, but it needs to be more accurate to actually be of more widespread clinical use. And we've identified that previous work done investigating contractility with the cuff shows poor agreement between the bladder pressure and the cuff pressure. We therefore wanted to investigate this and look to see if there are any specific variables that are actually affecting that error that we're seeing, whether that's the magnitude of the cuff interruption pressure itself, the stage in the contraction at which the inflation cycle is occurring, or the time point at which the void was performed within the cuff test. We also looked at patients who had more than one valid inflation within their cycle to see if the error was consistent between those inflations or if that was differing. So this is an example trace that we've generated from the previously held data via MATLAB. And that looks at the inflation, so the spikes overlying the urodynamic trace and the flow. And the peak of int is obviously taken at the point at which flow is interrupted. We did that by extrapolating a pressure flow graph for each of the inflation cycles themselves so that we could be sure we were accurate in the measure we'd taken for peak of int. All of the traces are analysed as per some previously set quality control criteria, which is available in the literature, but these include there being no flow recovery after the inflation, that the flow hasn't been interrupted by the pressure safety limit of 200 centimetres of water, or that the trace itself is just so erratic that you can't make a discernible measurement. So 110 studies were included, which comprised 318 separate inflations for analysis, and 71% showed that we got a pressure rise in bladder pressure during that isovolumetric period, which is what we would expect. In general, cuff pressure overestimates bladder pressure, and that difference is lower when we look at the cuff pressure and the bladder pressure at the end of the isovolumetric period rather than the cuff pressure versus a simultaneously measured bladder pressure. The standard deviation, however, remains similar for the two. And in those group of patients that had more than one valid inflation, 40% had errors between the inflations of just 10 centimetres of water. There seems to be a relationship between the magnitude of the interruption pressure of the cuff and the error that we're observing. There's a weak correlation between the amount of voided volume, sort of how far we are through the actual flow itself. And there's no correlation between whether the detrusor contraction was increasing or decreasing at the time of flow interruption. So in conclusion, most traces we saw exhibited that intravesical pressure rise during the isovolumetric conditions that the cuff test imposes, but nearly a third of the inflations didn't. For some patients, this was an underestimate of bladder pressure, and we think that this might represent some voluntary inhibition, and therefore improved patient counselling should help this. And when cuff pressure is overestimating what the bladder pressure is, we think that this may well be due to poor transmission of pressure through the penile tissue, and would suggest that using a correct cuff side would help. And therefore further work is underway. The current protocol includes making sure that there's a measurable and repeatable bladder volume, that we're using a larger size cuff, which previous work has shown is the better cuff to use to be more accurate, and improving our patient counselling to try and minimise things like voluntary inhibition and straining. Thank you very much. Any questions?
I have a question. Comparing cuff pressure with a conventional aerodynamics, you measure different pressure. How you can say that cuff pressure increase that detrusor pressure? Because different methods. You can compare. One is isometric pressure, the other isovolumetric, isotonic and isovolumetric.
Sorry, can you just repeat that for me? Could you repeat the question, please?
how you can compare two methods, because cuff pressure, you measure isotonic pressure. And conventional dynamic study, you measure isovolumetric pressure, isotonic pressure. So different methods, how you can compare?
So essentially when we're performing these investigations, and the protocol they used at the time is they do a few different cycles. So all the patients had standard urodynamics. They then had urodynamics performed with a cuff test at the same time. And what we're going to do in our future work is to do then a separate cuff without any lines in, so that we're losing the effect of the lines. The cuff interruption, so the cuff's on, the lines are in and measuring pressure, so we've got a constant reading of bladder pressure at the same time. So we can see what the bladder pressure was when the cuff interrupted the flow, and that's either detrusor or the actual intracycle pressure itself. So obviously we get lots of different measurements. What we've been comparing it to is intracycle pressure rather than detrusor pressure.
Andrew Gammy from Bristol.
Hi, Andrew.
Hi there. Thank you for this. I wonder if at least half of your overestimate of pressure is due to the fact that the cuff is 10 centimetres below the symphysis pubis, or do you correct for that?
Yeah, so the actual data itself, so if you look at some of the differences, on average was about 16.9 centimetres of water. Around 10 centimetres of water was that difference in the sort of transducer height where the cuff is placed compared to the pubic symphysis. So Stuart in his previous data had obviously commented on that, but that still leaves another discrepancy. And, you know, if the standard deviation was nothing, if the standard deviation was very small, then actually we would just have quite a fixed difference, and you could therefore say the cuff always overestimates bladder pressure by this amount, therefore you subtract that. But that's not what we're seeing. We're seeing a very large standard deviation, and that's what we're trying to really reduce to make it more accurate.
Thanks.
Thank you. And regarding the underestimation, the counseling of the patient, in your experience, is a nice method?
Yes.
Repeating the test, you have a favorable experience?
So we've been doing quite a lot of work recently with the low flow cuffs as well, and so we've been running some research clinics with that, and actually certainly, putting it on the patient's fingers and inflating it on their fingers so that they know what it's going to feel like, really talking them through, sort of saying, this is what happens when you strain, this is why we don't want you to do it, and actually there's, very little straining on any of the traces that we're getting, and patients don't seem like they're inhibiting. So even just from that, before we're moving on to this further work for this, we're finding that actually it's a much better experience for the patients. And I think yesterday it was maybe vaguely mentioned that it can be quite a painful experience, but in our experience in our clinics, it's actually, most patients tolerate it very well and actually prefer it to having lines in for urodynamics.
Okay. Thank you so much.
Thank you.
We move on. Congratulations.